Alrighty. Well, welcome everyone. Thanks so much for joining us today. My name is Miranda Harris Martinez. I am a fourth year medical student at the University of Minnesota and current Health Justice Fellow with the Social Mission Alliance. In this role, I have the privilege of moderating tonight's webinar as part of the Social Mission Alliance's Learner Engagement Initiative. Tonight's talk is titled No Margin, No Mission, Sustaining the Safety Net. For those of you who are new to the Social Mission Alliance, or SMA, we are an organization and a movement focused on training health professionals as agents of social change to advance health equity. And our Learner Engagement Initiative is a forum for health professional trainees and lifelong learners to engage in dialogues on issues impacting health professional education and the ability of our workforce to advance health equity in this country. We hope these webinars allow for greater inclusion of perspectives from community members, patients, educators, and org leaders. We believe this initiative will strengthen connections across SMA that are necessary to realize the collective vision that brings us all together. So this evening's goal is to share reflections on how HR 1, or the One Big Beautiful Bill Act, will impact safety net systems and healthcare access, and consequently, how we can urgently address these harms. Note that this will be a panel followed by an open Q&A, and then afterwards we'll have an optional 30-minute unstructured discussion. Also, heads up that tonight's webinar will be recorded. Now, I have the great honor of introducing our esteemed panelists for the evening, Wei-Yu Zhang, Dr. Jorge Otañez, and Dr. Toby Terwilliger. I'll invite the panelists now to introduce themselves with their name, their work, the organizations they represent, and a fun fact. Wei-Yu, why don't we start with you?
Hi, everybody. I'm Wei Yu Zhang. I use she, her pronouns. I am a policy director at this nonprofit organization called the California Pan Ethnic Health Network. Miranda, did you ask for a fun fact?
Yes.
Okay. Fun fact, I'm an artist in my personal life and I make clothes. Do I like popcorn it to someone? Maybe Toby?
Sure. Thank you, Wei. Hey, everyone. My name is Toby Terwilliger. I am an academic hospitalist in Atlanta, Georgia. And I also am a board member of the organization Physicians for a National Health Program, and I chair our local chapter here in Georgia. So through Physicians for a National Health Program, we've been building reports to emphasize how profiteering is negatively impacting the U.S. healthcare system, and especially in regards to the Medicare population, and also how a profit-driven healthcare system has contributed significantly to health inequities in our country. And more broadly, we advocate for single-payer healthcare reform. My fun fact is that I really got into running during medical school, and I have since run 8 half marathons, never run a full, but I'm planning to run my ninth in the spring. And I'll pass it over to Jorge.
Good evening, everyone. My name is Jorge Otañez. I am a family medicine and lifestyle medicine physician. I am the Associate Chief Medical Officer for TrueCare, which is a federally qualified health center in Southern California, specifically serving the counties of San Diego and Riverside. We care for close to 70,000 patients, and we have a variety of services in primary care and some other specialties as well. I've been working with this organization for over 3 years now, but I've been working for FQHC since I finished my residency over 7 years ago. And a fun fact, I am a huge baseball fan, and I am here from San Diego. And unfortunately, I root for the San Diego Padres, which have never won a World Series. So right now, World Series is going on. I think Game 4 is starting as we speak. And I used to play baseball growing up, and I initially thought I was going to become a professional baseball player. That didn't work out, hence I became a physician.
That's awesome. Thank you all so much for the introductions. Now let's get into our focus for today. As the federal government moves to cut funding to Medicaid, we are interested in its tangible impacts to both health systems and to people. So, our first question is, what impacts are you seeing or expect to see as a result of the HR1 cuts in your specific work? And is there anything you feel that isn't getting discussed as much? Let's go backward this time. Jorge, why don't we start with you?
Sounds good. It feels like HR1 can't be discussed enough. There's a lot of information that's out there. There's definitely a very structured way of getting the information and looking at everything that is written into that bill and everything that will be impacted when it comes to healthcare in general. I think the impacts are just monumental. They cascade down to the states and even for us here in California, which has a lot of a very robust protection for healthcare across the country. But because of that, just few people think of California as being someone that will have interruptions in care. I think a lot of things you hear out there when it comes to the emergency rooms and just like worsening like community outcomes when it comes to healthcare is something that we it's being talked about a lot, right? So even as we were sort of advocating against this in general when it comes to healthcare, that's a lot of things you hear, right? So people don't have access to care. They show up to the emergency room for things that we can take care at the primary care level. And then they just sort of overcrowd the emergency room departments as well. I think the impact will be real. It's here, especially for those who are affected by all of the changes and the healthcare providers that care for them. I think it's going to impact our patients. It's going to impact us as clinicians. We are the one taking care of patients. Although other people are making the decisions on behalf of the people in this country. Like we are clinicians and we're taking care of the patients. They're showing up to our clinics, they're showing up to our emergency rooms, to our hospitals, and that impact is certainly something that's it's going to be it's going to be quite big and very unfortunate. I think the increased eligibility checks and the work requirements and benefit cuts will push people off the coverage and will result in delays in care, especially for chronic conditions, and obviously cause this increased ER usage. And then the progression of this can be easily dealt by improving but having the access in the health centers and different places that provide this. Overall, we're going to see sicker communities and sicker patients. We've seen this a lot in the past as well, where patients delay their care because they don't have access to insurance, or they don't have access to care, and they're just going to come with more complicated, more problems are a lot more complicated.
Yeah, thank you for that. And since you're really working in the FQHC world and have been in that space for a long time, I'm wondering, what do you think the consequences that FQHCs specifically will face because of these cuts?
Well, depending on which state and where you are and what your sort of panel patients look like, some of the for sure we'll see more patients who are self-pay, and a lot of those patients, right? So like your mix can be, for us, like close to 70% of our patients are on Medicaid or Medi-Cal here in California, and our percentage of self-pay patients is much lower and has been decreasing, year over year with the way things are here in California. But that number is going to increase. Um, we, as an FQHC, have a certain pool of money that you're given to take care of patients no matter what they're here for. We, as an example, will see a patient and they can come in under a sliding fee scale, and then we'll see them, they'll do a visit, they'll do labs, they'll do anything we can do within the four doors of our clinic, and everything is covered with the nominal fee that they'll pay. Sometimes can be as low as $30, $40, and then we'll take care of everything. So we're going to have a lot more patients who are self-pay, and we are prepared as an organization to care for them. However, I don't think a lot of those patients are actually going to be showing up to see us and to see just and people in community health centers. And that's a big problem, right? So they might show up to the ER, they might not get care at all, and that's going to be a big problem. I think it is in everyone's best interest to be prepared and have the resources available to care for them. But some organizations might not be financially stable to be able to care for that growing population that's gonna not have insurance, right? Even if you have insurance, that's already a problem, and the access to care is just gonna become a lot more difficult for patients.
Yeah, thank you for that specific perspective. I appreciate it. I will hand off the question to Toby next. So, what are the impacts of HR 1 in your work, or have you seen any impacts so far?
Yeah, thank you, Miranda. And I will kind of just piggyback off of what Dr. Otania's said, because I think he really hit the nail on the head with this. Um, we're going to see more people who don't have coverage and who are foregoing a lot of the primary and preventative care that we know is very cost effective and efficient. Um, because of that, and Dr. Otanya has mentioned, we're going to see overcrowding in our ERs, which is already a huge problem. But I think more and more people who don't have access to care are not going to be able to go to primary care visits and are going to be forced to seek their primary care through the ER systems. We're also going to see people presenting with later and later stages of diseases, either chronic diseases or preventable diseases. And from the inpatient side, I do anticipate we'll probably see more people with what we know could be very preventable complications from diseases, whether that's late stages of cancer, or maybe they're coming in for diabetic ketoacidosis and they have diabetes. Um, conditions that we generally think we should be able to catch and treat early and prevent hospitalization. From a financial standpoint, we know that emergency care is much more expensive than is primary and preventative care. So I do expect, on a whole, this is going to lead to increased utilization and increased costs in the U.S. healthcare system. So as much as the current administration is saying that they're going to make cuts to healthcare spending, those dollars don't magically disappear. People are still going to need care. They're just going to be seeking it in less cost-effective ways. Hospitals and practices are going to be forced to provide more uncompensated care. That's care that patients are unable to pay for. They don't have insurance that can cover it. Um, with fewer people on Medicaid, that's fewer federal dollars coming into states and hospital systems. Um, this is going to lead to either states having to carve out more of their state budget to kind of rescue these hospitals, in which case they have to make cuts elsewhere, and things that may get cut are things like education, or else hospitals are going to have to make the difficult decision to close their doors if they can no longer sustain themselves. And the hospitals that I think are most at risk are going to be those in more rural communities, which already we've been seeing closing at increasing rates in the last 10 or 15 years. So I think this is going to have really far-reaching consequences, and first and foremost for our patients, but I think downstream effects on our healthcare system as a whole.
Yeah, thank you, Toby. I appreciate the perspective on the system as well. Wei Yu, you're coming to us from a bit of a different perspective. I'd love to hear how you're understanding these impacts and the cuts that you're seeing in your work more in the public health realm.
Yeah, also just to piggyback, it's really helpful to hear from the doctors and providers side of things. And so just for a little bit of a background of where I'm coming from. So my organization is a health policy organization, and we mostly work with the California state government to advocate for, healthcare that is equitable and universal and covers everybody. And so I think we've been doing like a lot of like building and progressive work up until Trump's second term. And I think even just during the first term, there was a lot of like defense effort to like protect the ACA, which is the Patient Protection and Affordable Care Act, that was passed in the 2010s under Obama's jurisdiction. So like it was, so this term, like, Republicans came back much more prepared to really cut things and repeal progress. And so that's kind of the broader landscape here. And our organization is also uniquely funded to really advance like racial equity, because we were funded after George Floyd, and really trying to build cross-racial solidarity under health. And so we're just kind of really situated in that like historic context, seeing a lot of the things like sort of like playing out and almost like repeating history that we saw, in in the last century of like welfare programs being like slashed. And so I think that I'm just gonna maybe go through some of the statistics here. I don't know who's on the Zoom call, if a lot of you guys are like coming from California. If you are, this information is more relevant for folks that are in California. But the estimate here is that up to 3.4 million people in California could lose medical coverage. And this is not even accounting for people who will have like losing coverage or become underinsured on the, market place side, also cover California, or like, they're obtaining insurance not from Medi-Cal, but it's a public program. And then the state, because there's so much like sort of pulling back of federal assistance of state funding, the California state could lose 30 billion in federal funding each year. And so that's like a really big budget downfall that the state, to, Toby's point, like the state government's going to have to, each state governments have to like come up and not even state, not just state government, but like local governments have to come up with a budget to be like, where else do we cut? And if the state and local government choose to sort of like backfill healthcare and other like, food benefits, they would have to like figure out how to do that. And so many of the things that you can like read about these digests of like the different provisions in HR 1, such as work requirements, really more of a reporting requirement, and then the eligibility check like changes. I'm not going to go into too much details, but if people have questions, I'm happy to answer them. But I think what isn't being discussed much is really kind of to the points that, other panelists have like sort of shared, is this broader kind of we're all at stake when these public option health insurance programs are being cut. Everybody in society is really at stake, right? Like I'm not personally on Medi-Cal, but if my local hospital, I go to Kaiser and Kaiser takes Medi-Cal patients. Like if Kaiser is being overflooded, it's going to impact my care too, right? It's weakening this broader like close to universal healthcare system that we have. And we understand our healthcare system is risk sharing, right? Like so if some of us are like not getting coverage or getting into medical debt or having like unpaid medical bills, the providers have to deal with that. And then everybody else is in this together, right? And so I think that's one of the things that is not being sort of discussed as much in my opinion. And then I think the second thing I want to say is that we really have to hold governments at large accountable. We know that this bill, like HR 1, is a bill that's sort of coming from Republicans and Trump, but we're also needing to hold Democrats accountable because what happened in California this year is that from January to May, when the state was negotiating its state budget, our blue state government preemptively cut a lot of benefits for immigrants in healthcare because they're like, oh, we're gonna have to reconcile this federal funding cut down the road, and we're already in this kind of hostile environment toward immigrants, and so like our governor cut a lot of things in terms of eligibility and benefits for immigrants in California, which is again repealing the progress we made from advocacy fields in the last decade. And so, and again, like next year when we come to like another round of state budget discussion, the California state is going to have to figure out like, how to backfill this budget and how to like prevent further cuts. And so it's not just the conversation of holding the Republicans accountable, it's also holding the Democrats accountable and making sure that when we vote, we're thinking about the consequences of like what this means for our healthcare as a whole, right? So I just wanted to highlight those two things as like things that I feel like are not being talked about enough.
Yeah, thank you so much, Wei Yu. I couldn't agree more. And in a place like Minnesota too, which is a blue state, we actually had a rollback of Minnesota Care, which was basically our form of Medi-Cal, where now immigrants are no longer eligible. So we're seeing it all over the country. So thanks for sharing. Which gets me to my next point. I want to know how you guys and the organizations you are a part of are responding to this. I think as a person who's entering the healthcare workforce, facing something big like HR 1 almost feels impossible and overwhelming. I'd love to hear the specific points of advocacy that you and your organizations are participating in. Why don't we start with Toby this time?
Yeah, of course. Thanks, Miranda. So, kind of leading up to the passage of HR 1, I think a lot of us saw the writing on the wall a little bit, and we kind of knew how damaging this was going to be even before the final version got I guess, introduced and before it passed through both bodies of Congress. So we had kind of preemptively scheduled some meetings with our senators. Now, Georgia, I like to tell people I think Georgia is still very much a red state. We have a Republican governor. We have bicameral control of the state legislature by Republicans, but we do have two Democratic senators for the time being, at least. And so we set up meetings with both Senator Warnock and Senator Ossoff's staff, and we kind of just explained to them the concerns from a healthcare provider perspective about what sort of cuts were involved in HR 1. Um, Now, I think unsurprisingly, both senators did end up opposing HR 1. So, that was kind of how we anticipated they would vote, but it was still good to kind of make those inroads and know that they had the support of our organization and I think the medical community at large in voting to oppose HR 1. Since passage, we've done a lot of kind of individual advocacy work. So we have a bunch of student chapters of the different medical schools in Georgia, and we had a one of our student leaders at the Medical College of Georgia. Her name is Daya Shaw. She authored an op-ed kind of talking about how the passage of HR 1 was going to really influence her ability to practice medicine once she graduates from medical school and she's starting as a resident and a new physician in the workforce. Just trying to tell a little bit different perspective about who is being impacted by this bill. Obviously, yes, patients, but our the future of our profession is going to be really harmed by this bill as well. And so I think that was a very powerful story that she told, and that was published in Common Dreams. And there, back in June, there was a national pause for Medicaid that our organization took part in, and so we had doctors and students kind of demonstrate outside of various medical centers throughout the city, holding signs saying "Protect Medicaid," "Medicaid saves lives," stuff like that. We took photos, posted on social media. It was organized by this group, Physicians for Medicaid, and so we tagged them as part of their campaign. And then another hospitalist and I wrote an op-ed kind of about that action and about the impacts of Medicaid cuts. So, I think trying to find ways individually to fight back, try to raise attention. I think a lot of this also has to do with educating and particularly educating our patients who we know are going to be put at risk by this bill. And again, to Wayu's point, like we have to hold our elected officials accountable for their actions, and ultimately that comes down to um, the voters and being educated about the issues and understanding the impacts so that they can make a decision that's in their own best interest. So yeah, that's we've been busy. Obviously, this is a very difficult issue to tackle, but we're trying to do our part as best we can in our communities.
Yeah. Thanks so much, Toby. I appreciate the learner perspective too, and especially you guys taking the role on educating health professional learners in this because this is not included oftentimes in formal curriculum, how Medicaid works, our institutions get paid. So really important work y'all are doing. Wei, I'll hand it to you next. What are you guys doing in response to HR 1?
Yeah, so earlier this year, two kind of parallel things were happening for California. So one is I was kind of mentioning that the state budget negotiation for budget year 2024 to 2025, which started in July this year. So the negotiation was happening from January to July. And so during that time, the state of California already proposed a lot of cuts that essentially peel back like progress we made covering immigrants in California. And so including things like, no more like enrollment freeze and people now immigrants have to pay like a premium to get Medi-Cal, which is Medicaid in California. And then also repeating like dental benefits for immigrants. And so there's a lot of things that are already in that kind of state budget package. And so we did a lot of like advocacy and defense with our network of advocacy organizations to just respond to the state budget and knowing also like there's like another bigger battle to be fought like later next year. And so I will say it was very like it felt very daunting because just the environment is so unprecedented. So that's one thing we were doing. And I will say we did win. We had some like small wins this year with our state budget fight to protect healthcare. So for example, like in the January draft, the premium that was going to be imposed for immigrants was going to be $100 per month, and ended up being like $30 per month in the final budget. So that was like a small win. And I honestly, it's really hard to attribute like who did what, like what contributed, but like we were able to kind of negotiate with the state. So, but then the other parallel thing is HR1. And so a lot of the bigger organizing groups in California have been leading this campaign called Fight for Our Health. And so there's actually a landing page for Fight for Our Health. And if you want to like sign up to keep up with the campaign or support, show up when there's like in-person events, I highly encourage you to do that. But essentially this year, the Fight for Our Health campaign, as HR1 was moving through different houses and like different versions of being negotiated, we were targeting 3 congressional members in California. So they were kind of like the swing votes, or we thought we could change the votes, but they ended up all voting yes on HR1, which is devastating. And so now it's like holding them accountable to sort of like when they are running up for re-election and whatnot, like really educating voters in those districts of how their representatives voted. And so I would say those are the things that we did like prior to this point. Right now, our team is very much like all hands on deck doing organizing and educational work about HR1. I would just say there's like a huge disconnect between the health policy that policy wonks understand and then average voters understand. Because if I think about like the past 15 years since the ACA was passed, it's like if you ask the average American, like they're not going to know what that is, right? They're not going to know what that is. They wouldn't know what it did. They wouldn't know all the protections and provisions that were put in place. They're going to associate it with like Obama or like Democrats and whatnot, right? Like there's a lot of propaganda and misinformation that has been circling. And if you look at sort of research results, like Democrat voters and Republican voters are very much split on their attitudes and beliefs about social assistance programs and welfare programs. And so I think we've just been doing a lot of kind of like education, like going back to the basic of like, let's just like boil this down and digest this for average people to understand. And so CPEN does work with a really wide net of like nonprofit organizations across the state. So we've just been using our network and spreading kind of education information and just really going back to basics, being like, what is even this like ACA adult expansion? Like, what did that do, right? And why are Republicans taking that away? And then what does this mean? And what is this like kind of sort of like health care 101 knowledge building for our folks? And so and these folks are the on the ground, service groups or their base building groups, and they're interacting with average voters on a daily. And so just kind of spreading that information. And because we know that next year, when the California budget draft comes out in January, it's going to be another huge battle, right? Because the state will have to figure out like what are we going to deal with all of the federal funding pulling away. And this is just in the little corner of like healthcare, which is a big battle, but not to like underplay, groups that are still fighting for, abortion access or like gender affirming care. Like there's just a lot happening kind of across the board. So trying to sort of organize everybody around kind of like a shared understanding.
Yeah, that's incredible. Really excited to look at the accessible resources y'all have made. Jorge, I'll pass it off to you. What are you guys doing in response to HR1?
Yeah, so similar to Toby's organization, we unfortunately anticipated a lot of those policy changes, and uh, that enabled us to proactively increase our efforts to support things like enrollment and patient education. Instead of backing down, we started reaching out to communities that often lack those resources and provide education, right? So that's something that it's been really important for us. So in our clinicians, our patients, like our leadership, everyone here in general, like everyone, we're constantly providing that education so people can hopefully make informed decisions, right? And that extends into the voters, extends into everyone. So everyone's affected by this. So we've been really proactive about providing that education to people and also in the community as well, recognizing that we are a healthcare organization, but we also understand that, just 20% of what impacts someone's health is what we do within the four walls of our clinic, and there's this 80 other percent that social drivers of health and so many other things that are really impactful in someone's health. So it is very important that we're able to recognize that as well. And then also recognizing that many people are going to lose those supports led us to increase all of those educational efforts and just making people aware what can they do after that happens, right? So campaigns to let people know, like, this is what a slide and fee scale is, right? So that's been out there, like that's something we need to provide. And then just providing that education to our staff. So when a patient shows up to our door and they have no insurance, or like they have a different insurance we don't take, we don't turn anyone away, right? You're going to come to any of our health centers and you're going to be seen that day, and we're going to try to do our best to care for you within the four walls of our clinic, and then having those community partners as well to ensure that we're all doing this together. When it comes to the advocacy side, some of us have been engaged through association, like for instance, myself, the Association of Clinicians for the Underserved. I was in DC a few months ago and like meeting with representatives as well. We do this here as well, right? So there's constantly that opportunity that we have to meet with our local representatives and state representatives to have those conversations, which is something that's really important, right? Not because we're in healthcare, it means that like we're like this is what we do, and then the advocacy and other things. We have a department. We have a couple people here who do a lot of that work with us here, and we've been able to engage those elected officials at different levels of the government to help mitigate those effects of HR1, and then also understanding that the budgets, as it has been mentioned a couple of times already, at all levels are overstretched, and that we're advocating for regulatory reform to help ease that burden on health centers. Just for those who are not aware, right? So community health centers in 2024 care for over 34 million patients in the whole country. At least 1 in 10 patients that receive medical care in this country are cared by community health centers. And around, this data from like 2024, and you can go look in that 25 and the years that are coming after, around 80% of those patients are uninsured, 90% low income, and around 64% are people of color. There's over 1,500 community health centers across the country that are doing this work. And I think there's, definitely power in numbers, and there's also a lot of power in the education. So I think that's something that we are really ensuring that we do at all levels. Again, like I said, with our patients, with our staff, with our clinicians, and ensure that we have and dedicate the time and effort that this deserves to ensure that we can focus on what we're here to do. I think it's been, in a way, a distraction. Sometimes it feels like you're being attacked from different places. Like we're here to serve our patients. Like we don't have a difficult job enough to do already to um, practice medicine and take care of patients with all the different issues that are out there, and then throwing everything that's been happening recently on top of that to the work that we do every day. It has been very difficult, but I think as an organization, we are, our roots are very deep, and we're ready to we're here for our patients, right? So there's different campaigns that we're doing to ensure that everyone is aware that we'll be here no matter what. We're constantly trying to find ways to deliver quality of care. It's not just like being here and like seeing someone else as another number. Like every single patient that we care for has a name, and we're here to serve them. And I think a lot of the health centers out there in this country look at things in a very similar way. We're all in this together, and we're working towards the same common goal. And I just hope that we all continue to partner at not just the state level, but federal level as well, to ensure that we can continue to provide that education and continue to bring to the forefront when decisions are being made. Why is it important that we consider certain things? Because as Toby said, like this is not just, or like someone mentioned this, right? So like it's not only impacting those who are going to be an insurer, those who are on Medicaid. this affects every single person in this country that receives healthcare. So it's something that's really important. So we're going to continue to do this work and be here and show up every day for our patients.
Thank you so much, Jorge. All of those answers were really excellent. And something that speaks to me across all of your answers is this theme of anticipation and how we need to be anticipating these changes and these needs. Which leads to my last quick question before we open it up to the rest of the audience is, as the future of this policy landscape is changing and is tenuous, and now we're seeing cuts to other things like SNAP benefits, for example, how do you suggest that health professional students, healthcare workers, and community members advocate about this issue in the future? We'll start with Wei Yu this time.
Yeah, I think it's kind of what I was addressing earlier of this disconnect of just the average person's knowledge about not just healthcare and the interconnectedness of, our health, but also this idea of like, as a society, do we have responsibility to support the people who are in need, right? And I think I really think people can engage in ways big or small in their own capacity because 2025 is just has been very exhausting and we're all doing our best but I think we can find ways to stay engaged. Like, and I'm gonna tell you to like go to a rally or like talk with like go to your like local city council meetings and whatnot, because these will be trickling down to the local decisions, right? I'm saying like, even if just to have a conversation, I don't know, for Thanksgiving or Friendsgiving or whatnot, with people around you about like these issues, because I think we are at a pivoting point in America of talking about values, right? Talking about what our society values. And because I'm an organizer, like I firmly believe that change needs to happen from like our like immediate environment. Like we cannot be fighting Twitter walls with wars with each other and not having those conversations with people who actually like know us, right? And so I just think even just like you being having the knowledge and the degrees and then the professional background you have in this general field of health, spreading those awareness and discussions with the people around you, like that would really be my suggestion. And it does not need to look at some like very like dramatic or robust like political action.
Thanks, Wei Yu. Jorge, I'll hand it off to you.
Thank you. I think a lot has to do what I just mentioned about the education. I think so. The question is, in the future, I think we can advocate right now. Like this is the time to continue to do this and build on what's been going on throughout this year, even where there might not be, it might not seem like there's any directly relevant bills in healthcare that are being passed right now. I think our elected officials and leaders need to remember the day-to-day impacts that the policies that they're deciding on and what that happens, right? So like you decisions were made, right? So we need to constantly remind people and have those conversations and say this is what's going to happen. This is what will continue to happen because there's going to be other things that are going to come up, right? And other decisions that have to be made. We can take the time to continue to educate ourselves on the policies, develop a strategy that we can advocate or against something based on the effects that are going to have on the community, right? So people unfortunately sometimes make decisions based on so many things that are personal to them or different interests. But I think we can't be selfish. It's not the time to be selfish, and we need to unite as a community and provide that education to everyone. To my point before with the previous question is educating. I think that's something that's really important. The more you do it in an easy way that people can understand this and understand that it impacts everyone. And in addition to that, we can always depend on our community partners. I think that's something that's really important. Like I said, we as a healthcare entity, we can't do this work ourselves, and it takes everyone. It takes a village. And then the priorities that we have as a healthcare organization, our community partners have, are often interconnected. So I think that it's really important that we align. And then the work that each of us individually do work only grows stronger when we join forces. So I think there's definitely something that forming those community of care ecosystems to ensure that we are stronger together. And most importantly, we need to ensure that our patients also remain educated, right, and engaged with everything, because this is, everyone, has the right to vote, and like the decisions that you're making today are going to impact what's going to happen in the future. And we need to help them understand that voting is also critical to their health as well, not just our staff, but our patients as well. So I think it's something that I think in the last couple of years has become, at least for me and many around me, has become more clear that we all need to be doing a little bit of this work as well. Again, like I said, like we don't have a difficult job enough to do already, and we also have to be worrying about those things, but it's truly that important.
That's awesome. Thank you. It absolutely sounds like you are nourishing that ecosystem. And Toby, last but not least, please tell us how can we advocate about these things in the future?
Yeah, of course. And I think that Wei Yu and Jorge already really covered most of what I was going to say. So um, I would just add, I think that it starts with what we're doing right now. I think a lot of this is about building bridges. We, I think, are all parts of communities or organizations that are advocating or um, working on behalf of different interests. And I think as much as we can come together in venues such as this, come together online, come together with individuals from other institutions, and present a united front. I think that that is going to go a long way towards kind of showing that the healthcare profession stands for our patients. We stand for expanded access to care, and we stand against any sort of legislation that is going to get in the way of that. Um, I'll just add that I think also it is building bridges with an interdisciplinary team. So keep in mind that like nurses and nursing students are central and always have been central to social movements throughout our country's history and throughout our country's healthcare system's history. Um, what Jorge said about community organizations, patient rights organizations, and and also within organized medicine, right? I think many of us are involved in different societies within our organization or within the AMA, pushing the leadership of those institutions to stand by our values. The AMA has been on the wrong side of a lot of social movements in history, and I think kind of has made a lot of progress in terms of being more progressive and representing the evolving needs of doctors and our patients. But I think continuing to push big organizations that have a lot of money and a lot of lobbying power has to be part of this movement. So yeah, I think the more that we come together, share stories, center our patients, I think that's what's going to lead us to be successful.
And on that note of coalition building, I will open it up to our audience for any questions that they may have. You can come off mute or happy to answer questions in the chat. Charles, go ahead.
I appreciate it. Thank you. Yeah, I'll come off camera. Why not? Yeah, thank you all for offering the space. It was really great to hear this. I guess quick intro. My name is Charles. He and pronouns. I work with a communications nonprofit affiliated with UC Berkeley called Berkeley Media Studies Group. Way you. I was just about to say hi. We work really closely with CPEN. They do great work. Um, this Medicaid issue is very close to our hearts. With Berkeley Media Studies Group, we support health professionals, organizers, journalists to push out messages in the media that support public health and healthcare, as well as health equity. And so everything going on with Medicaid has been very close to us. We put out a recent guide for people to be able to talk about how Medicaid is affecting them if they want to do policy advocacy or want a framework for how to frame those arguments. resources like that are available from our website. One other thing that's really top of mind to us is that this isn't the only social safety net that's being deteriorated in this moment. We have, of course, SNAP benefits that are going to have serious impacts on our communities, not just from what happened in the One Big Beautiful Bill Act, but also with the government shutdown, those funds are going to be exhausted come November 1st. And so I just wanted to ask how folks are engaging with that, how they're interacting with their patients, if you're working in a medical setting, on those kinds of impacts that will be coming very quickly and will have, chronic disease implications for the quick near future.
I can start. This is even so last at some point last year, right? So we started screening our patients for food insecurity and different social drivers of health. Been collecting data, and we made the decision as an organization to screen for three things that we have some sort of power or a way to actually affect change, right? There's a lot of different SDOH like screening tools that you can utilize and information you can collect, but we made the decision that we're going to go with three that we can actually have an impact, right? So for food insecurity, we obviously what we do is like we partner with organizations like food banks and different organizations are out there. So to provide, so we'll see the patient, we'll ask them if they're like a couple questions, and they screen positive for food insecurity. Then they'll leave with a the list of resources, right? That like you can go here, you can go there. As an organization, we do food distributions as well at a couple different sites, and where patients know that's open to the community. You don't have to be our patient, but our patients are very well aware of that. So we share the resources, but um, that's not enough, right? So we're constantly trying to find other ways that we can help patients with this. So then we started this pilot program working with the food pantry at one of our clinics, right? So we said, okay, what best, like what other things you can do than like have a patient that's telling you in the clinic, when I'm in the clinic and I see them like I don't have anything to eat, it's very difficult for me to like try to focus on patients with chronic conditions on like eat healthy and do this and do that when a lot of those patients don't even have access to food in general. So then we okay try to put together a food pantry pilot, and like you can leave with food, and then here are the resources, right? So this will take you like 2 or 3 days worth of food for a family of four, and then you can go to the food banks, you can do this. So we're literally actively and that's what I was doing just like 40 minutes ago, like talking to someone about what we're going to do when it comes to like for the future, right? What other we're having active conversations about how we can continue to partner with those organizations, but we also know that those organizations are likely to be affected as well. So like what can we do, right? I can't sit in a patient room and tell them to do all those things when we can't when a lot of them don't have access to food, right? So we know there's a lot of data and numbers are only going to increase, right? Of like what percentage of the U.S. households have uh, access to adequate food, right? So one thing is that you're food insecure, and then the other thing, another sort of newer concept is nutrition insecurity, right? So you can have access to food, any type of food, which sometimes people that's all they need, but what kind of food are you actually having access to? So beggars can be choosers. I understand that, but like we're not going to give up, right? So we're as an organization, we're trying to find ways that we can help our patients to do that. So we're it's part of our strategic plan and like partnering with the organizations and having those conversations. What else can we do, right? So like there's the talk of the food pantries, there's talks of like different things that we need that we can do, and look into other organizations that are doing that work to find a sustainable model. Because again, we have to understand that our mission and what we do here is to provide quality healthcare to patients. And we're not in the business of food and things like that, but it does affect healthcare, right? So it is that important that we need to be paying attention to that, and have those that what as I spoke about those community of care ecosystems informing all of those things. So it is very top of mind, and we are trying to find ways that are sustainable to help our patients with that. And um, yeah, so that's what I can say in regards to that.
Toby or Wei, you any other comments to add?
Um, uh, Thank you for that question, Charles. I think that is, such a great question and is on the top of many of our patients' minds right now. Um, I work for an institution that has really recognized, as Jorge was saying, that access to food and particularly nutritional food is a social political determinant of health. And um, so has implemented a food as medicine program where right on site they have access to like a pantry of nutritional foods that certain patients who are food insecure um, and have certain chronic diseases are able to access. I think moving forward, now everything is um, so magnified, both with the upcoming snap cuts that are included in HR1, but particularly with the government shutdown that was just announced is going to affect the November SNAP benefits. And so I don't have a great answer. I think that I've been reaching out to some community organizations. I think that it's going to have to take the shape of some form of mutual aid. I think that the existing food pantries are going to be working overtime and whatever we can do to donate volunteer support either with our um, our hours or with our money, I think is going to be more important now than ever.
Yeah, I'll say one thing we're trying to look into is just how much do local governments have power in sort of, you know, I don't want to say backfill because it's impossible with the cuts, but it's just like there are a lot of like indigent programs and local safety nets. And so, food banks are one of them. And so like just to kind of shift the responsibility, shift the focus to county governments, um, in addition to state government to see if they could secure some of the programs. So there's a lot of pre-ACA programs too that offer like I think Jorge was talking about sliding scale, right? Like stuff like that, where some folks can be covered potentially through local programs. So we're doing some policy analysis on that front, looking at a couple of the California counties to see like what still exists. The other thing I do want to say, like mutual aid is, I think it's mutual aid is like not so complicated as like checking in to see if your friend has something to eat. Like I think it's happening to my friends too, because I have friends who are like on Medi-Cal and like on SNAP, and they're literally like worried about not having like basic needs met. And I'm like, I can help you out. Like I don't know. It's like not that complicated. And so I do think as there's things that we can do in our personal capacity in addition to the professional capacity. And I'm a firm believer on like on until everybody is willing to truly like unlearn the individualistic way of like the American life and the capitalistic way of American life, it's really hard for us to like win this battle against the right wing. So yeah.
Thanks so much, Charles, for that question. We will go to Sarah for her question.
Hi there. I'm Sarah Hartfelt. I'm a family practice doctor in Minneapolis, and I'm on the board of our local chapter of PNHP with Miranda. So, I think I'm nodding along with a lot of what you're saying, and I find myself feeling sort of frustrated and angry because I don't for a moment question what you all are doing, and I wonder if you're still continuing to play a game by an old set of rules. And so I'm thinking about some things that might be sort of some different ways to sort of take a stronger sort of moral stand as a medical profession. And the first thing that comes to mind are things like unionization. We actually have a group here in the Twin Cities where the primary care doctors voted for a union in 2023. And our local group called Alina has been dragging their feet on a contract. So they've actually announced a one-day strike that's coming up in early November. And I'm thinking about things like the phrase I use a lot is how do we make it easy for doctors to be brave? Because I think we as a profession and as humans who feel a lot of we're by nature incredibly conservative, right? Like we always try to do the most conservative thing clinically. We feel, understandably, and we're very protective of our patients' privacy. And when it comes to like making statements and being public, we tend to be incredibly like in the background. And so I think the, I'm thinking a little bit about, or wondering a little bit about, even just in a whiteboard kind of a way. What thoughts are people having about how we start to play a new set of rules? How do we start to move towards some non-compliance? How do we start to really call upon our profession to have to really put ourselves out there more? And how do we support and protect each other if we start to try to figure out how to do that?
Sarah, I thank you for the question. I have been grappling with this a lot myself as well because I completely agree with you. Like, I think and I'm not by any means an expert in history of labor movements in our country or in the course of world history, but I do feel like if what we were seeing happened in another industry, if what the government actions that were taken that are impacting our professions were happening in another industry, I feel like there would be strikes and there would be walkouts and I think because we view ourselves oftentimes as like the layer between a patient's life and death sometimes, or even just like their well-being and not well-being, we don't necessarily feel empowered to take that position. But this is a terrible non-answer because I don't know the right way, but I think that these discussions need to be held. And I think that we need to look to labor movements for um, examples and advice.
I don't also don't have a concrete answer, but I completely understand where you're coming from because I've been every single day for like months and even before this year, like constantly thinking about the work that we do and why we do it and why some people feel more comfortable about saying things than others, and we are sort of in the background and like, oh, yes, sir, I'm going to do everything, and this is not the time to do those things. And as I've been saying, I think it's at what me, at least myself, right? So what I can do, what I have control over, is to educate myself and try to understand and show up and be part. I mean, part of so many different, one would say, too many committees and boards and different things, and trying to get myself involved to try to again come together and try to make change, right? And then also educate as an administrator here, educate our clinicians, educate our staff, and be at the tables where decisions are being made. As a clinician, yes, the responsibility is always to our patients, but I don't know what the right answer is. But I agree that a lot of different things have to be done differently, and um, I've been reflecting a lot on that as well, and like talking to others and like what is the right answer, like what can be done and what are you guys doing, and like that sounds really interesting. Maybe we can, you should talk to this person, you should talk to so and so. So um, you know, yeah, I don't know. It's more of a reflection than a specific answer, but I totally hear you and understand where you're coming from because I feel there's a lot of us feeling the same way and thinking that way, and perhaps some of us are having conversations with people about different things. So yeah, that's what I would say.
I'm not a doctor, but I really appreciate what you said, Sarah. And it sounds like you have ideas on how doctors and the other health professionals can show up. Um, I just recommend really digging more into the sort of the political education side of things. Like, I mean, like I feel like this is a time to really connect those dots and, understanding our own privilege and understanding like how the system becomes like I was reading about like the New Deal and Reagan today I was like, damn, this is like literally what happened back then of like slashing, welfare and then painting it on like black and brown people, and now it's happening to like immigrants, right? So I'm just like, I'm froze, sorry. There's like, it's like no different than what happened. Like, I think history does repeat itself, and Republicans are blaming on like Medicaid being too costly and prices, rising every year and whatnot. And so I think this is like a very familiar narrative. But on the other side, I gain strength from learning about history because health has always been political, right? Health has always been political in this country. If you look at the examples of like, the Chicago Young Lords or the Black Panthers, like their like activism around health and healthcare, it's never been separate from the political realm of things. It's always been something that people have to fight for. I think, um, yeah, and as an organizer, again, like I think there are things you can do in your capacity, in your comfort, and just starting small, right? If you feel not comfortable even having a conversation about Medicaid with your neighbor, go do that. Like I think you start small and you build up the momentum because again, the movement requires everyone to commit to changing themselves and how they show up on a daily basis. It's not about the dramatic actions. I have my understanding of the current organized labor groups in the US, and I think they're also very late stage. And there's also been a lot of political division of like sabotaging like labor movements in the US. So if you look at the labor movements in the US, it looks very different than what's happening in Europe, right? And so people often are fighting for their profession instead of class solidarity. And so I think it's like there's a lot to be said about labor movements too in the US. But again, I'm like, we need to really radically reimagine what is possible. And that radical thing does not need to be anything that's further than taking the first uncomfortable step in your personal life, whatever that looks like.
Awesome. Thank you, Sarah, for your question, and thanks to our panelists for their answers. We are at time, so I just want to say that we are so grateful to Wei Yu, Jorge, and Toby for sharing their expertise and insights today. I feel honestly like reinvigorated knowing that we can come together as a community to resist this moment and confront the harms of HR1. And I'm sure our audience feels similarly. And thanks so much to our audience for your attention, your questions. If you're interested in keeping up with what we're doing here at the Social Mission Alliance, please follow us on social media, or you can sign up on our website for our newsletter. I highly encourage you all to learn about SMA's For Us All campaign. This is our new advocacy initiative fighting for transformative health justice through social accountability of health professional schools. Um, we'll send those links in the chat. And if you're interested in becoming closer to this community, I highly encourage you to attend our biannual conference where professionals across disciplines come together to exchange ideas on how to reorient the social mission of the healthcare workforce, which is what I think really all of our panelists spoke on today. Our next conference is in March of 2026, so it's coming up.